Okay, I think we can get started. Why don't we go ahead and we can go around. I'm just going to call on the members I see and just introduce yourself for the record. And Abby, do you record this? Oh, it is recording. Thank you. I see that. Let's get started. I am going to start on my screen with Kristen Sheehan. Just if you could just say hello and where are you from?
Hello, I'm from Rutland.
Great. Thank you, Kristen. Next is Eileen Murphy.
Eileen Murphy, family nurse practitioner, primary care in Orange County.
Great. Next is Faye.
Faye Homan, family medicine in Wells River at Little Rivers Healthcare, which is an FQHC over on the eastern side of the state.
Excellent. Next, I see Tim.
Hi, Tim Tanner, internal medicine pediatric primary care clinician, work in Danville and now medical director of Northern Counties Healthcare, FQHC, based in St. Johnsbury.
Great. Tim. Michelle.
Michelle Wade, nurse practitioner, acute and primary care, and I'm here representing Vermont Nurse Practitioners Association. I work in Randolph and live in East Wallingford.
Great. And Amelia. I got it. Yay.
Yep. I'm Amelia Florence, family physician at Gifford, and I'm their clinical coordinator for their primary care as well.
Thanks. And Lee. Oops, you're on mute. Everyone's saying hello and then just where you're from.
Right. So hello, and I'm from Danby, Vermont, work in Manchester, Vermont for myself.
Great. Thank you. And then John King.
Yeah, hi, I'm John King, family medicine in Milton, Vermont.
Super. And then from the state, I want to start with Brendan Krause, who's joining us. We had talked in the past about inviting folks from the Agency of Human Services. So Brendan has kindly joined us this evening. So Brendan, if you're in a place that you could just say hi and maybe a little bit about yourself and your role.
Hi, I hope you can hear me driving back from Montpelier. Brendan Krause, thank you for inviting me. I'm Director of Healthcare Reform and working closely with the Green Mountain Care Board on the healthcare transformation efforts that we're engaged in.
Great, thanks, Brendan. And then we have Dave Merman.
Hi, Dave Merman from the Green Mountain Care Board. I've been to several of these, so I think you probably all know who I am pretty well at this point, but it's always good to be here. And just for the record, John King and I probably live about, I don't know, 3/4 of a mile at most apart. It's not that short to get from one house to the other. It's probably, but there's a ravine in between. But it's always nice to have a neighbor on too.
That's awesome. And Dave, I maybe this is a good time to just say you are the designated board member that will come to these meetings. You're not going to be able to come to everyone, but
yeah, I think I'm sorry I missed the last one. I think it overlapped with our April vacation with right. Kids. We had a very nice but long road trip. So we were driving a lot, and it was pretty tricky to figure out time to hop on meetings virtually, even though it seemed like there was lots of time when one would think one could hop on a meeting.
And I see Rob Penny just joined. Rob, just hello and where you're from and your practice area.
Yeah, Rob Penny, family doc, and mostly retired, but volunteering at the People's Clinic in Barrie.
Great. And then I don't want to leave you out, Stephanie. Stephanie, why don't you just introduce yourself and your role in the state of Vermont?
Sure. Stephanie Winters. I am the Deputy Director of the Vermont Medical Society. I'm also the Executive Director for the Vermont Academy of Family Physicians and the American Academy of Pediatrics Vermont chapter. And this is Parker, and it is normally cuddle time, so he has to be in my lap.
I think that it looks like therapy. I wish I had my own here, but he's a border collie and probably really wouldn't be into that. So, okay, so we have a robust agenda in only an hour. I'm gonna tee this up on a couple of areas. I'm gonna first turn it over to Dave in a second, but before I do, Dave, I want to go back to some of the things that I think it was Faye who proposed in the past, some options for this group. And I just want to tee this up that as we walk through this meeting, I am just going to put out there that I think in terms of our structure, we might want to consider more of a leadership role amongst you. And I don't want to forget that. So we could go to Dave first, but I want to make sure we discuss that today. And I think it'll come up as we're talking about your role. But I think that teeing up that discussion will be really important. And I think, Dave, if you want to just, I assigned a couple of things to Dave that he graciously offered to delve into. And so we'll turn it over to him and then maybe talk more about the charter.
That's great. So I guess the first thing, I'm just going to maybe we'll do this first and get this sort of settled, and then I think kind of break into a larger conversation. But the first thing I want to talk about is the UVM settlement with regards to primary care. And I think that when this was sort of a concept, I had a different concept of how this would be implemented than what it came through in the settlement. But from my understanding with regards to settlement, that it's essentially up to UVM to figure out how to use this money as described in the settlement agreement. And so I think the intent there is to basically backfill the CPR payments for the year. I don't think that other than that there's been much defined in the settlement agreement, and I don't think the care board really has much authority other than, it has to meet the terms of the agreement. So that is that's that, and I want to bring it up. I obviously wish there was more mechanism, a bigger mechanism in which we can provide direction on that. Faye.
Oh,
you're muted.
God, you'd think I was a beginner at this. I wanted to know what the acronym was that you said. Backfill the
CPR. So the OneCare has the CPR program for
okay.
primary care providers.
ACO. And now it's, do you remember? I should know what it stands for. Now I'll look it up. What is it?
Comprehensive Payment Reform.
Yep.
Thank you.
And does backfilling that mean continuing the payments that had been stopped, or does that mean paying UVM back for money that they spent on it? Or I wasn't sure what you meant.
So I don't know specifically what it means, but in the settlement agreement between the Agreement on Care Board and UVM, they agreed to, I believe it was $11 million that was allocated within that agreement for non-hospital primary care practices in FY26. I would have to pull the agreement, which I only have a draft one actually in front of me, so I'm not exactly sure the specific language, but I think that's what was roughly agreed to. Sure, Stephanie, you're probably pretty.
Go ahead, Stephanie.
So Faye, this is money that's going away, one, because OneCare is ending, and two, because we're entering the AHEAD model. So there are a few practices that are receiving quite a bit of money to help them sustain. So it hasn't gone away yet. It will go away at the start of the next budget session. I have so many follow-up questions, but it is included in the budget, the state budget as well. So, just laying that out there.
That's actually a really good point, Stephanie, that the state, and I'll pop up that language too. The state budget, which actually just got signed, I heard today, which is a huge accomplishment for everyone. I thought there was just not actual money, but an assurance that this followed up, that there was a follow-up. There was actually money, additional money, but I think it's different money. I'll double check. Anybody else had a question? Tim, go ahead.
And this is a what and who question. What's the mechanism for assuring UVM lives up to their end of this settlement, and who's monitoring it?
Yeah. Dave, I could take that, but you could take it too.
Why don't you?
Yeah, I'll start. You can add if you need to. The mechanism is the settlement agreement. And if the money is not sent out to the providers, the primary care providers that are listed in the settlement agreement, then there are actions that the board can take per the settlement. The mechanism is to be determined by UVMMC-HN.
Yeah, the mechanisms for distribution of the funds, the mechanism for monitoring it is probably through the independent liaison and through the board's budgetary mechanism, the hospital budget review process. But I think there's an intent, at least thus far, for transparency and to try to get this done fairly expeditiously and not to get it dragged out.
So I definitely don't understand a lot about the ACO and these payments. With the limited understanding that I have about the big scope, does it sound to anyone else like UVM was more or less fined for some behavior that wasn't, or some actions that weren't supported, but then the money then gets used for stuff that they were going to use it for anyway? I'm not sure.
No.
I'm not sure I get it.
So it wasn't a fine.
Ahead,
it was it wasn't a fine. It was it was a settlement, an agreement. And then the OneCare goes away at the end of this calendar year. And then if the state does pursue ahead or continues to pursue ahead, that wouldn't start till 2027. And with regards to the primary care payments, it doesn't start in full effect in 2027. But this money would continue conceptually, and my assumption is that it's not going to be 100% perfect, continuation of the CPR program. There's probably going to be some variance from it, but to continue distribution of that money or some amount of money similar to that, to similar practices in 2026. But it's not clearly defined, and it doesn't have super tight guardrails in the settlement agreement. But theoretically, OneCare is going away, so it's not money that UVM would have spent in OneCare. I missed the comment. What was the, Stephanie, you put something in there, didn't you?
She just put in the text of the budget language, which is really helpful. I was just writing. Thank you, Stephanie.
Oh, wow. Okay.
I think Lee has a question, Dave.
Oh, Lee, sorry. Thanks.
Yeah, so I think the phrase you used somewhere in there was non-hospital primary care. What is that? I mean, so many primary care people are owned by their hospitals. I mean, obviously where Faye works, you know, community care practices are not involved in that. But, you know, if you work for Gifford, are you hospital primary care or are you not hospital primary care? Doesn't sound very clear to me.
I'm not 100% sure, but I believe at Gifford, it's not the FQHC owns the hospital, not the hospital owns the FQHC. So I believe when we look at primary care attribution numbers, that Gifford falls in the non-hospital based primary care, and it's an FQHC, is my understanding. But I'm not,
We're oddly special. We know that.
You're both.
Yeah.
I guess the other question though too is when they say hospital based, do they mean only internal UVM primary care? So it doesn't seem like they're feeding each other. Is this anybody outside of them as a hospital? Maybe is that the better language question?
Yeah, we'll follow up. How's that as how that's defined? I think that makes sense so that we get it right for you all. Is that good, Dave?
Yeah.
Thank you for
all
your input on that. Yeah. Should we? Go ahead, Dave. You
are
go
people
to
comfortable
the next one.
moving to the next topic, which is, I think, Susan, if I'm getting this right, this is some thoughts about what the PCAG is, what the future of the PCAG and what it can be, and some thoughts that we've had about this as we've been talking about this. And basically, so these are my comments, and I guess I should always say that, I'm on the Green Mountain Care Board, but this is always my, my views aren't the views of the Green Mountain Care Board, and they are mine alone and all that sort of stuff. But my view of the PCAG is that this is a really great opportunity to take the perspective from people who have an incredible amount of experience of working in primary care in Vermont and help advise the Green Mountain Care Board to use our authorities, the statute that applies to us, the rules that we have, or we can go through rulemaking processes to improve healthcare in Vermont, of course, but really to strengthen primary care, increase sustainability for primary care access, and empower primary care to do what everyone wants primary care to do, which was to help take care of people, thus reducing the cost of care and all of these sorts of things. So, and I think that from the standpoint of being a board member, I think it's trying to figure out how we can use what we can do. That we have limitations to our scope, and we have our primary regulatory duties of hospital global budgets and commercial insurance, CON process, and really being a party to health reform. But we have a lot of limitations within primary care. We can't, we can, through the health reform process, work with Medicare, but we can't make Medicare directly pay more. We can talk with AHS about the impact of Medicaid in primary care, but we don't directly oversee Medicaid in any way. So I think that's what I'm hoping for, is that we can figure out how the care board, Green Mountain Care Board, can really specifically use our authorities to improve primary care and get your input on that. I think that's sort of my general view of, like, because we've been having all these discussions of, like, where and how should the PCAG relate to the board. And I guess that's my general thought. I don't know if people have reactions to that.
And Dave, I probably shouldn't have started with this chair idea at the first thing. I'm very worn down today. I didn't sleep well last night. But I think this is a good time to say, what is the structure of this group? Because I think that, in my view, and again, I'm just teeing this up, that like re-teeing something up that I believe Faye had mentioned in a letter a little while ago, that I think that there could be, that structure could make this group's views more directed and more focused and more impactful.
Yeah. Tim?
So Dave, just looking at, your agenda for the next 2 months and all the meetings that you have as a member of the Green Mountain Care Board, what meetings, what topics, issues could you see, like, I'd like to get primary care's take on this thing,
Mm.
what are the things on that, we would be advising on? I'm just looking for examples.
The big next topic that's coming up is commercial insurance, QHP, small group, and having, your thoughts on what we should do about that, how we can. We're really worried about, especially the Blue Cross Blue Shield rates. This is a contested case and it's coming up, and we all, but these are now public rates. But I think there's concern among many people about these rates. How can we use this process to improve primary care sustainability in some way? Public comment within the commercial rate hearings is really helpful because it is a contested case, meaning so that all of what we're really allowed to deliberate on is what occurs in the record of those hearings. So we do have public comment sessions, but submitted written public comment is also really helpful because that then becomes part of the record that can be used for deliberation. Similarly, in the hospital global budget, not the hospital global budget process, I'm so ahead in my head, but the hospital budget process in August and September, there's the general concept of there's a pot of money, and that especially smaller independent primary cares have not been able to leverage for that pot of money as well as other parts of the healthcare system. And having your comments and views delivered through that process is also very helpful. Anytime people come on and give public comment at the end of a hearing, sometimes it's hard to sit through the hearing. It's really impactful, and it's really helpful. Written public comment is also great, and it gets read by everybody. But those are kind of two areas that are the big things that are coming up that I think having the continued primary care voice loud and clear at the table to bring your concerns forward will help bring your concerns forward.
And Dave, just to kind of overarching all of that, maybe that's why I'm really tired, is just I don't have to say to any of you, just the state of the healthcare solvency amongst many, if not most, of our providers.
Okay.
So I think most of the people in PCAG have seen these emails. I may have gotten it started, but I know Eileen weighed in on some of it about, just sort of a little soul searching about this group and how we can be more effective. And I think we had a good discussion about it last time. I also think that, to me, it would make sense to have, like a more traditional meeting, agenda items, action steps, something that we could circle back to at the next meeting and say, did we get this done? I think that will probably take somebody to run the meeting. We've always been a nice egalitarian group, but I think sometimes when we don't all agree on something, the conversation is robust and we never get to any sort of, I think sometimes we tell a lot of stories that illustrate how frustrating things are, but we don't get to the step of here's what we recommend or here's what we'd like people to pay attention to. So that was one of the things I thought we could talk about was sort of, I sort of hate to say chairperson because I'm not, first of all, I don't think anyone really wants to do it. And secondly, I don't think I don't think it's really about anyone having more authority, but I think our group would have more authority if we did that. Yeah. So I don't know, just see what the rest of you have to say about that would be good.
Can I give one comment on that, which is that I do think the stories are really helpful for contextualization. I think that if they could be brought into other meetings where there's a full board there, I think the impact of those would be greater. Because I hear you, and I work in clinical medicine, not primary care, but I hear you. But I think to continue, like it, are they going to move mountains overnight? No, but are you going to influence how people think about things, and it becomes one of the various things that factors into decisions? Yes, absolutely. So I do think those things are still important, but I completely agree, to become more effective, I think in moving things forward, I think it would be helpful to have some more structure. John, did you have?
John, you're on mute.
I think this is maybe a corollary to Tim's question, but it really helped me. I don't know, maybe others have a better understanding of it, but I don't really understand what the levers are that you have that you can use. I understand you set the global budgets for the hospitals, but it's kind of hard for me to translate that into what parts of the, how does that translate into supporting primary care? So maybe as you're coming up to these milestones where you need input, if you could tell us what it is that you can do, because I think we get a little frustrated maybe because we talk about all things we'd like to have happen in the system, but obviously you're only working on a very small part of it, and maybe the commercial insurance or something, and what influence you have over that, and what can you do that would support primary care. That would really be helpful, I think, at least for me.
John, I think that's a really great point, and I've been thinking about this over the last month a lot more. One thought that we had was maybe at our next meeting is having someone from our legal team come actually prep some slides to speak through, where our authorities overlap with primary care. When I look through the PCAG survey results, and Brendan, I'm sorry to say this, but like a lot of these things I think are really better directed towards AHS than towards the care board, which I know AHS is, buried right now with critical things to manage, but this is a critical thing. So but there are things in those themes that I think we do have some relationship to. So I get, to me, that's one thought, was to have Mark or
Mike or
if someone from our legal team come in who can sort of walk through some of this just to help understand what our levers are, and maybe we can get to some of that today.
Yeah, that's right, Stephanie. Which also passed today, S-126, and thank you for folks who did come in and testify. You all did great on a drop of the hat notice. I think one of the things that came out of it, as Stephanie said, is that AHS will be administering a primary care steering committee as part of S-126. Brendan's driving. She also said, Brendan, sorry, Brendan, but so important. So important. So. I think Eileen was
I was
next.
leaving space for Brendan if you have any thoughts you want to add to this, because I know you're probably can't unmute and put your hand up. Or maybe he's in a hollow.
Yeah, he might be in a hollow.
Yeah.
It just came through Williston, so that'll explain it. I think we need to maybe take stock of sort of what comes out of conference, and then look at what already exists, because I know there are a number of primary care committees, so we would want to kind of streamline and understand, what the purpose is of each. But I'm coming at this a little green, so I think that would be our first step. But my understanding is that there is a steering committee in the House version of the bill, but I don't know. I'm sorry, I'm not sure what happens in conference, so I don't really know much more than that. But I'm happy to report back from our legislative team.
And Stephanie, you seem pretty up on.
Stephanie, yeah.
Could you?
We may have helped draft the composition of this steering committee.
All right, well, tell us what to do.
Yeah, we have so many ideas. That's the point. The point of this was really to make sure we all say that primary care is the backbone of healthcare, and yet don't often have a voice at the beginning of what's being built. And so this was an S126 has a lot to do with hospital transformation and payment, but there's this one piece that is a 16-member steering committee, and it is really meant to start to plan what health reform, payment structures, primary care should look like, and inform the process to make change. So I'm excited about it. I don't want it to be one more primary care group. But Brendan, just for your information, I mean, we have been impressed with the way that Pat Jones has run the primary care ahead work group and really come out with actionable items and really gotten feedback from the group. And so we are hopeful. And I know Chair Lyons has asked us what we want to keep from 126. And we're like, well, the primary care steering committee, like that's
Right.
That's what we care about in the bill. So I'm happy about that.
Eileen?
There we go. My thought before these other comments came up, and then these other comments are on the same page that I was going to speak on, which is the primary care piece. What can we do, or what can a primary care group do that has power, authority? Where's that connection fit in? And then what can this group do, and who are the best people, and how do you do that? So if there were Green Mountain Care Board or AHS meetings coming up, how do you pull people in? And are there, it sounds like there's several primary care groups or primary care individuals, and it sounds like that needs to be pulled together. If the steering committee is going to help with that, that might be a good thing. So it's not just the what needs to get done and identifying those things that can, I'll say, legally or statutorily under which group can do them, but then who also is involved in doing that. So we as a group have identified a number of issues that are quite useful and quite helpful, but where should they go? And then which individuals should do that? And then my plug on having actually read through the text of S126 is I'd like to see a PA and an APRN on that steering committee. And I didn't see that. But that doesn't mean the committee is set yet. Not at this point. Thank you.
Can I just make a plug for, it seems like there's a substantial growth within primary care providers as PAs and APRN, and that APRNs, and maybe that the proportionality should be somehow representative there as opposed to just one of each on a 16-person committee.
I would second that, Dr. Merman, and thank you for saying that. Sorry, I didn't put my hand up. We were honestly just thrilled to be at least written in. Thank you, Stephanie, for thinking to do that. But I do agree that we should look at proportion.
Tim?
Yeah, a comment also stimulated by the discussion, but it's sort of a question too. And listening, sort of going back to what you said, Dave, about envisioning how we could help the Green Mountain Care Board with those meetings. I mean, for me, I would need to have an informed opinion of what this means for primary care. I mean, I don't understand all the actuarial stuff. So there's got to be some kind of interface to translate that. And if it's a human being, it almost sounds like, a primary care person needs to be an ad hoc member of the Green Mountain Care Board without voting rights to be, you got to be there through all of that to understand it. And then to be able to then inform the rest of the PCAG as to, like translate to get an opinion. So is that something that it would really increase the work a lot for this group or an individual on this group? And I don't know if that's the chairperson if we move forward, but then the other comment is, are we irrelevant now that there's going to be a primary care committee for the AHS where the money is and they've got the levers?
Points.
I'm not sure if I know, I think it would be pretty complicated to add a new position to the board in that way. I think, I think basically speaking, and I think Chair Foster's been pretty vocal about this through the meetings, is this concept that there is an amount of money, especially within the commercial market, but also I would say within Medicaid, that is there, and and in the commercial market for sure, the leverage goes towards larger providers with market power. And there's arguments in Vermont of what market power means because we're regulated. We have regulated hospitals. So some people argue that there is no market power, but I would argue we've seen substantial use of market forces this year. In so far as if a hospital doesn't get what they want, they make decisions that impact the healthcare landscape in Vermont that are kind of flexing market power. So the argument has long been that when money goes to places other than primary care gets less. That's the argument the insurance companies make. They only have so much money, and so they get less. And it looks to me like that the entities that have the least ability to negotiate / power tends to get the least commercial insurance reimbursement increases over time. So one area is, within that hospital budget process, which would be a very indirect way. Another area that's been discussed a lot within this legislative session, is reference-based pricing, which is rate setting. And so the Green Mountain Care Board does have the ability to set reimbursement rates. And the statute on that is actually fairly interesting. I don't have it in front of me, but the way I remember reading it a few months ago was that there's a fair amount of flexibility in how that's implemented. It could be in a sector of healthcare delivery. The way I would read it is that you could probably just pick one practice and rate set one practice if you wanted to. You could rate set primary care, you could rate set endocrinology clinics, you could rate set FQHCs, you could rate set an FQHC. And that means that the board would have to go through a long process of rulemaking, could potentially set reimbursement rates for primary care specifically. It gets complicated, right? Like, what is primary care? What's a primary care service? There's codes and whatnot, but that is in the statute. Never been implemented, but it's in the statute. That would be an area that I think would be interesting to talk about.
We could tee that up too for our legal team to review, be part of the statute review. Thanks, Dave.
Does that include like fee for service and potentially like capitated payment?
I think it's just fee for service.
There would have to be a lot of rulemaking involved. Yeah. If we were to do commercial hospital global budgets, that would fall under the rate setting statute. There would probably have to be additional legislation, maybe not, and maybe it could just be done through rulemaking. I'm not, I'm not an attorney, but that I would say that includes a cap. So a hospital global budget is a capitated payment. So, could we through rulemaking, I guess what I think you're asking, John, is could we through rulemaking establish a commercial capitated rate set model in Vermont? And I don't know the answer to that. But this is where these conversations, I think, could be pretty helpful, because if that makes sense, then we should work with the legal team and sort of go through the process. This is not an overnight thing.
I mean, I'll just thinking about that. I mean, that just seems to me like a huge potential for figuring out where, where do you need primary care in the state, and where can you incentivize getting it to where it's needed? Which populations? I mean, we have quite a bit of data about the population and where people are unhealthy and and need access. I don't know. Obviously, money doesn't do the whole thing, but that just seems like a lot of potential. I realize that would be complicated, but that does seem like a lot of potential that the Green Mountain Care Board has as a lever.
So I'm hearing a follow-up item, definitely with a review of our levers / statutes and how it relates to primary care and what the levers are. I think somebody asked, maybe it was Tim, about the levers, or John, about the levers in each process. And we can review that too at our next meeting. Should we?
Can I just
talk-
sort of add one
go
quick
ahead.
comment to that? Is,
Yeah.
John, I think you've just gave a lot of, that's a great example of why if we were, why it's really good to have a primary care advisory group. Because I think that being able to get that kind of feedback, if we were to pursue this pathway, if there was support for this, if this made sense for the state, to have your perspectives loud and clear at the table on how this would go. Because I think, I think we all have real concerns that primary care is really not sustainable in the way that we want it to be, and that really gets in the way of a lot of good health reform, because we need it to be better than sustainable. We need it to be thriving to do the rest of the transformation that's needed. So thanks.
I'm looking at the time. We did have teed up a review of the primary care priorities survey results. We did send those to you beforehand. And if you want to talk about that now, we can. And then the other items we wanted to talk about were the charter revision, which I think that leads to the formation and the structure of this group that we touched on. And then if we have time, we've been talking about this already, but some of the legislative updates. So what's your pleasure, group? Would you like Abby to summarize quickly the primary care priorities, or am I seeing yes? Okay, great, because she's ready to go, right, Abby? Thank you. And thank you for doing that survey, Abby.
No problem. And see, Faye is already a natural chair because she gave a thumbs up for the group. So, okay, so these were the key themes. It's just kind of what everyone touched on. 9 people participated. So there's a lot of uniformity, payment reform, reducing administrative burden, kind of a lot of these things that came up in the last meeting: workforce support and development, improving access to care, enhancing health information technology, legislative and policy changes, and then stabilizing primary care infrastructure. So the general themes were essentially how much of a workload primary care handles, considering how little funding it gets, burnout, lack of support staff, fear of provider loss, what we were talking about before with the pot of money, shifting funding towards primary care. And then really what we're all here for. We know what needs to change, but what's the path to make it happen? And I think that's where having the lawyers on and talking about our levers is really important. So none of this is, I think, shocking or brand new, but it kind of ties everything back in together. And so I sent these out in the email, but if you for some reason didn't get it, let me know and I'm happy to send that along again.
Thanks, Abby. Nice job. Any questions, comments, next steps here?
Just kind of my usual. So this is great that there is so much uniformity in, you know, eight out of 9 mentions for many of them, but it's my usual question of, so what do we do now, gang? Who do we talk to? Who needs this information? How can we push anything along?
Go ahead, Eileen.
I think that's actually my question too. This is amazingly consistent for the time I've been on this group, several years now, that it is very consistent, no matter who attends the meetings, that this is what the priority is. So not only the next step, but there's now going to be a primary care steering committee. There's primary care committees sort of, or subgroups across multiple groups. Is that one going to be a center? Is there still going to be other people? When does it start? Because we've got this queued up. We've got this ready to go. We've been doing this, and where does it go next? And what happens next?
Lee, can I just comment? Just one comment on that. So when I read through this, I looked at a lot of this, and I think there's things in here that the GMCB can be involved with. You know, we are involved with, with AHS on looking at ahead and payment reform. I think some of this is potentially legislative, like annual increases to primary care rates to match hospital rates. Some of this to me seems like it's related to AHS with and legislative within sort of Medicaid components of it with rates. One of the things that I don't know much about, and I would love to learn about, and it's within sort of the charter of the GMCB to deal with workforce support and development, but I don't think we have many tools or authorities directly related to that, but expanding lower payments, scholarships, recruitment, incentivization, which could go into payments. But to me, I think that's an area that I am not super familiar with, but I don't know what to do with it. But I do think that I'm excited about the primary care steering committee, but I'd like to get a lot of this to there and then figure out where in state government this could work. But I think we can look through this list, and I think maybe it would be good for me to and Susan and Abby to meet with some people on our legal team and look at our statute and try to figure out where can we crosstalk some of these things, and then come back to you with where we see, our authorities aligning with the needs that we have within our primary care community. I'm just thinking of that now, and I hope I didn't just create a whole lot of work for Susan and Abby and I, but I think it actually wouldn't be that hard to do. Yeah. And then we can come back and sort of, that way I think we can orient the statute and the rules and, and our authorities with the need, as opposed to just sort of, okay, here's a dry, I'm sorry, I'm just, this is just idea generation now. Here's a dry presentation about our authorities. Let's try to figure out if we can match them up. And then where we don't match up, I think, that will be helpful with having Brendan involved in AHS to figure out where does AHS match up. And, how everything is. I mean, Stephanie's just gone through this, and Susan with the legislature all years. You have a whole list of things that you want to try to get done, and if you can get 1 or 2 done, and they're meaningful, and then that's good. I don't see getting everything done quickly, but let's see what we can do. I'm sorry, Lee.
Okay, well, I just wanted to first of all say that this has been one of the more exciting meetings I've come to, because I actually think that we're starting to hone in on what we can do with the Green Mountain Care Board. And I think we've been talking up to this point. We haven't been doing. And that's, I think, big. Now, the other thing I would say is that, I'm sitting here on the Green Mountain Care Board. Maybe I'm not paying enough attention, but I did not know there was a steering committee that was going to be coming out of some bill in the legislature. And I did not know that there was a head primary care steering committee. I think we need a list of all the primary care groups, and we need to be working together. And having, maybe we're advising the Green Mountain Care Board, somebody else is providing AHS, but we need to be working on the same agenda. Because if somebody's telling AHS something and we're telling the Green Mountain Care Board something else, that divides it. I mean, they both may be true. We both may agree with it, but we're emphasizing one and someone else is emphasizing another. And that ends up doesn't seem to me to be as productive as if we were all talking to each other and figuring out, who's you've got the AHS levers and you've got the Green Mountain Care Board levers, and you guys do this and you guys do this, and coordinate that, rather than having all these committees out there that I didn't even know existed.
I think it makes, sorry.
Go ahead.
So I just think it makes a lot of sense. I think one of the challenges that we may need to sort of figure out how to navigate is the open meeting law components. So like, what's a quorum and how many of the members of the PCAG can talk at one time without, breaking open meeting law, which, I mean, I'm just going to throw this out there, hypothetically speaking, would it make sense to actually not have a PCAG, but have an informal PCAG so that you can have conversations that are outside of the open meeting law, but still have an impact? I don't know what the right answer is there, but I completely agree. There's been discussion of this, that there's multiple primary care advisory groups with the AHS, and Pat Jones is with the head, and this new steering committee. So I totally agree that there just seems like, and I'm like, keep looking at Stephanie, like thinking like, is this actually where VMS, or some outside entity could work to try to help coordinate this, which might change the relationship between, the formality of the PCAG as an entity, but I don't think anybody's too caught up on the formality. I think we want to get stuff done, like it's less about, the titles of these things and more about them being effective, in my view. I think probably shared view. Stephanie.
Yeah, thank you, Dave. I think I agree with that. And I think, Lee, to your point, I think there is utility in having some separation, but also someone to sort of manage the overarching what's happening. And that is what a lot of your professional organizations do for you, keep track of all of these things. But like the primary care work group for AHEAD, that was specifically for AHEAD. This group I see as specifically as what it's supposed to have been made for, specifically advising the Green Mountain Care Board. And originally, in the absence of having any clinical expertise on the board, but I think, primary care has so much to do with every decision that the Green Mountain Care Board makes. And so I still think that there is great utility in this group, but to use it as more of an advisory group to decisions of the Green Mountain Care Board, come up with these ideas, that's great. And then we figure out where they go to actually have action made on them. Because a lot of these things I see as they're legislative. They are through AHS, they're health reform. There are a number of different organizations who are doing them because we don't have a, Faye's not our healthcare czar yet, which the House Healthcare Committee hated that term, but we'll have to think of a different one. So I still see utility in this in some separation, but then also a way to come together. Like the steering committee in 126 has a member of the primary care advisory group is named by the Green Mountain Care Board, so that there's cross connection and then can bring, you know, ideas from or to and have that bidirectionality.
Can I throw out a thought? And I don't know how this works, but if the goal is to advise the Green Mountain Care Board on the decisions we're making, I don't think we've achieved that goal. You get it to me or Owen or the board member that comes, but we're not getting it to the full board. So is there a role for a position statement on the topics that come before the board by the PCAG to advise the board, either written or through testimony at a hearing? That, you know, I mean, I'm just throwing that out. Is that something that people would be interested in doing? And I think that would create, I mean, there's a lift to that, but I think it could be more effective. Eileen, or yeah.
Everyone likes this idea or not.
I think this set of priorities that's written is what you're asking for. That is what we've talked about. And so I think this list of priorities could be just formatted into something to Green Mountain Care Board, and we wouldn't have to do yet another step other than just formatting this to, this is a position statement, this is what we want to have addressed.
I'm happy to take all of that and work with you or Faye or whomever to just, or like run it by you to make sure you like it. So then it's not adding extra work, but it's also not me swaying it at all.
Because I think everybody agrees that this is what we wanted. This is consistent. It's what we've been talking about. It's more just putting it in the format that Dave is outlining. And I'm happy to help with that. And I'm sure Faye will too.
And I know we have other people talking, so I'll be quick, but I think, yes, but I think what Dave is also saying is, as we are going through our regulatory duties, that this, you look at the rate cases, you look at, you know, the public information, and you have a position that you share with the Green Mountain Care Board. That's what you're saying, Dave. But I think you're right, Eileen, and it's building on your priorities. So
I think that's correct going forward, that yes, it's a response to each one or each topic or group of topics, but this is a start.
Yeah. Go ahead, Faye.
I think Michelle's first.
Oh, sorry, Michelle. Thank you, Dave.
It's okay. It's okay. It doesn't matter. I mean, Eileen said most of what I was going to say. What I was going to say, though, also is you hit the nail on the head, Dr. Merman. That's exactly what we've been trying to say for an extended period of time, is that we have this data, we have this information, and we've never been able to successfully get it to the entire board in a format where it's being reviewed and seen by everyone. To the point to that, that's why this year in legislature, in both the House and the Senate Healthcare Committee, there was discussion by myself, by people from Stephanie's teams, from people from other organizations, about members of PCAG need teeth in the legislation so that we have to be heard. And so that was brought up a number of times this year in legislation as well. So I think you hit the nail on the head.
And I was just going to say, I agree with Eileen that, you know, this survey with such unanimity and all this is, I think our wishes are clear, but Dave, if you thought it was helpful to have a member of PCAG present this to the Green Mountain Care Board or come to a meeting, if a human face is more memorable than an enclosure in an email, I think let us know that and we can fight over the opportunity.
I mean, I think it would be helpful, and maybe I'll talk with Susan and Owen and the team and figure out how we can facilitate that. But I do think it's sort of a yes and situation, that this information, and like, if we it's I think it's a hard ask, right? Like, so what I would love is for you to look at these commercial insurance rates, and of course, we can have someone walk through to some degree the filing, I hope. I don't know, Susan, how we do that with the contested case. It can't be a board
We can
member,
only
but
do what's out in the public. Like we couldn't have a conversation like we have with the board,
right.
but
No.
but there's a lot of public information.
Yeah, there's a ton of public information, there's in the record.
Right.
And then if you have an opinion about what we,
Right.
What we should do with those rates, then we would appreciate it greatly. It's a complicated topic. It's a complicated topic. So I think, if just broadly speaking, if the rates get approved as what they are, that's a huge impact on a lot of your practice's ability to pay benefits. And if they don't get approved as what they are, then it's a huge impact on, the solvency of our insurer, the access to insurance, or potentially, reduced payments to providers. So it's complicated, but try to figure out a way to pull you into those topics, though.
Yeah.
Lee?
I think it was Faye first.
Oh,
I
don't think she took her hand
legacy. Okay, go ahead, Lee.
How many of these quote unquote contested cases are there, Dave? I mean, how much stuff? I mean, could one of us take, each contested case, or two of us or whatever, and hash it out, and then, or are there 10 of them?
So
I don't even know what the scope of that work is what I'm saying.
I mean, there's effectively 4. There's MVP and Blue Cross, each have a small group and a individual filing. I think that the binder I get is like that thick. Now you don't have, a lot of that's confidential, so you couldn't read it. And the reality is, I think to weigh in broadly, I think you could probably read 20 to 25 pages of it, and you would get a really good flavor of what they're asking for and what our actuarial analysis is of it. But I think we would appreciate thoughts on that and on hospital budgets. So yeah, but I understand that this is dense stuff, and I'm not asking you to do my job for me, because it's not the most pleasant thing to read through.
Well, if I could just add to the comment there, that if it's 20 or 25 pages, we should just have Zarfay or Zarina Fay assign people. I know she loves that. So, but we have to pick up. I think having 2 or 3 of us say, we're gonna, we're willing to take that on and go appear before the Green Mountain Care Board, as long as we know dates and things like that well in advance. We can. I think that's doable, and if it would really help you guys, then and us, then we should do that.
And we'll follow up after this meeting and send you the link to all the publicly posted information on those submitted rates for the qualified health plans, so folks can delve into it. But I think that the hearings are in July, and so any kind of a statement would have to be done by then. And that actually, I know we're over time, so I did want to talk to you a little bit about the schedule. July and August are incredibly tight for us at the Green Mountain Care Board. I know we were trying to do once a month, and I was wondering if we could put in a meeting, like maybe Abby can go out with like a doodle poll to see what works, but have one meeting between July and August, if that works. If folks want to keep it July and August, we can. We can always add a meeting if we need it too. That works. Okay. And we didn't, thanks. Go ahead, Faye.
You should probably finish your thought because this is.
No, I was just gonna say, we didn't get, yeah, we didn't get to the charter, and like, we still have work to do on that and the structure. We didn't really land on anything. Maybe that's where you're going, Faye.
No, actually, I was a whole conversation back when we were talking about open meeting.
Yeah.
If we all as PCAG are emailing each other between meetings, is there any open meeting? I know if we were standing somewhere talking together, we would have had to.
That would violate open meeting law if there's more than a quorum. I have to look at the numbers.
Even emailing?
Mm-hmm.
Because we had that thread going when we were asking for ideas and sharing ideas.
For the survey? Yeah.
Yeah, and before that, when we were kind of working on things. But we can also tie that in if we have Mike or Mark come to next month's meeting.
We've done this before. We've done this analysis before. I'll dig it up. But there are open meeting law concerns.
So would that mean we shouldn't email each other, or would it just simply mean that those are all discoverable or have to be publicly posted or something?
Right. Yeah.
Well,
what we had done to limit that before was just to agree that for a couple of things we did, only a couple of us were working on it. And that's how we kept that number down. Yeah. But that was content that everybody had sort of basically agreed to, and that a couple of us were working on it outside, and that kept it down to not open meeting. We didn't violate that.
Okay, but if we did all email each other as a group, we just have to bear in mind that it's all discoverable, or does somebody need to post it somewhere?
It is discoverable. I mean, any of the work we do here is discoverable, and because it is we are a state agency, that's separate. But I think Eileen was keying in on the point of having the quorum issue. If you are emailing the whole group, you need to have a public meeting. If you're meeting as a quorum, it needs to be a public meeting. So it couldn't be like, oh, we had this email, now we're going to post it. It's more of you're coming together as a quorum. And so if you are, you need to be in the public forum. And I can dig up that information. I think that would be a good reminder as well, Faye. Thank you for bringing that up.
Okay.
Dave is very familiar with it.
Yeah, I mean, the advantage of the open meeting law is transparency. The disadvantage is, and we deal with this a lot in the Green Mountain Care Board, is it has the potential to stifle kind of collaboration and innovation in a safe way where you feel like you can speak freely, because sometimes you throw out some ideas that aren't that are proto ideas that might inspire a different idea, and that idea can just go away in the trash can. But when it's an open meeting law, then sometimes those ideas are public for the record and may not feel like the most intelligent things.
So we are over. I know we had to stop a little earlier tonight for scheduling, but we'll follow up with some dates for the next meeting, and then some follow-up topics. And I'm like a broken record, but maybe get to the structure discussion and take that up at our next meeting if folks are good with that. Okay.
Is there an opportunity that that Abby could send out some sort of structure poll concept, and we could get some kind of aggregated information similar to this
sure,
document, so that we can kind of get started before the meeting with what are some people's views on the structure, and then And then one way to get around the open meeting law, or not get around it, but one way to be compliant with the open meeting law is that
Very good.
what then what Abby can then do is send that back out. So then you're not deliberating.
Right.
She's
Just informing.
putting in a de-identified
Right.
compilation of what the views are of the group, and maybe we could sort of get the structure conversation rolling before the meeting, so
That's a great idea, Dave.
we could be more efficient in our meeting.
Yeah. The issue is when you start having conversation and ideas and all of that over email. But what Dave is explaining is completely appropriate to share out information. Go ahead, Eileen.
The last document that went out after a previous meeting had a bunch of those ideas in there as to what we were looking for charter content and discussion.
Right.
So there is a document that has some of that already in there that we've talked about or had ideas about. So I think that's the one that I had pulled together with Faye.
Yeah.
And we sent out. So
All right. I'm the one with the scheduling conflict, and
Yeah, you're the one
I'm over,
turning
so I
into
got to
something.
run. But
Go ahead, Dave.
thank you so much, everyone.
Thank you, everyone. I don't see, besides Stephanie, members of the public. So I'll open it up for public comment if there are any. Do not hear any. Thank you all. Stephanie, I'm sure you've updated folks on your world on the legislation. You already did. I think we covered most of the legislative stuff that it's almost done. We're just watching a couple more bills, but it's been a long session. So, and I did see, I want to congratulate Dr. King and the group from, I always forget the name. What's the name of it?
Maple Mountain Consortium.
Maple Mountain. How can I forget that? Congratulations. That's really exciting.
Yeah, we're super psyched about it. It means we can move forward.
Awesome. Let's end on that good note. Forward. All right, we'll be out with the next date and then some more follow-up information that you guys have compiled, and we'll get input and send it back out to you. But we should have a meeting probably in June, and then see where we go from there. July and August is when it gets really hairy. Okay.
All right.
Thanks all.
Good night.
Take care. I feel like going to bed. It's been a long day.